Well, many thanks for the introduction and invitation. Now, the topic that I was given is fairly large and very general. And I tell you what I'm not going to do. I'm not going to give you a rundown of examples of the WHO classification of brain tumors, because that you can read in books. Given the fact that the subsequent speaker talks about perfusion imaging, which is normally a favorite topic of mine, I'm going to focus on diffusion-weighted imaging and contrast-enhanced imaging. I think in routine imaging, these are probably the two most important sequences to grade and to have a differential diagnosis of brain tumors. Just by way of introducing, this is the latest statistics from the Cancer Research UK, and you see that the incidence of malignant and benign brain tumor increases sharply with age. Now, the most common tumors are astrocytomas. They actually include glioblastoma in there because it's an astrocytic-based tumor, 95% aggressive, and then meningiomas, and then a whole lot of other tumors. So my talk is going to focus on glial tumors, the imaging characteristics, and how you can use DWI to further characterize it. Then I'm going to talk about non-glial tumors, where diffusion-weighted imaging can be useful to diagnose. Differential diagnosis of cystic lesions, some other more solid pseudotumoral lesions, and lastly also some differential diagnosis of extraaxial mass lesions, because meningiomas are very frequent tumors. So kicking off a brief overview of the genetic pathways, we all have to learn more about this, but from the stem cell there's a mutation, the IDH1 mutation, and then it can go either a pathway of an astrocytic or an oligodendrocytic tumor. So the next slide is that there are two different pathways to have a glioblastoma. One is via progression of a low-grade astrocytoma to an anaplastic and then secondary GBM, or another one is de novo. Now, the vast majority arise de novo, and they have some typical features like EGFR implications and so forth. There are now imaging correlations with different gene defects, but it would be too much in this talk to go into that. So let us start with a typical adult low-grade astrocytoma. This is a WHO grade 2 lesion. It's an infiltrative lesion which typically affects part of the limbic system, like here the insula and the temporal lobes. It's bright on T2 and bright on FLAIR imaging. It shows no contrast enhancement. What you see here is the middle cerebral artery, which runs through the tumor. And if you look at the ADC map of the diffusion-weighted imaging, it is normally brighter than brain. Now, you have to know that on the ADC, if it's brighter, that means there is more water diffusion than the normal brain. And here is another example of a low-grade astrocytic tumor, fairly homogeneous. You know that on what we call normally the diffusion-weighted image, which is actually the trace-weighted image, and my teaching point here is that this is not only giving you information about the water movement, but it has also a T2 effect. So why don't you see it there? You can actually hardly miss it. This is because the T2 should make it bright, and the increased water diffusion, which you show on the ADC map, should make it dark, and then one goes up, the other goes down, so it's zero, and that's called T2 masking. So the message is here, never ever look only at the diffusion-weighted image, look always in combination with the ADC map. You can see that this gives you the true information about the diffusion. So, what about the WHO grade oligodendroglioma? Oligodendroglioma they have a different cell line, and they also arise from different genetic mutations. Typical features are location in the frontal lobe, calcification on the CT. Then they have a slightly more heterogeneous appearance on the T2 weighted image. You already see on the ADC map there is more structure, more texture. It's less heterogeneous. And then on the T1 weighted you get high signal areas which may either be calcium or even small foci of enhancement. So even if it's an oligodendroglioma and if it enhances a little bit, it doesn't mean that it's a high grade. The difference is if an astrocytoma enhances, that means it's a higher grade. And I'm sure the same will be mentioned in the next talk. You can also have an elevated regional cerebral blood volume in oligodendrogliomas. That doesn't mean that they are high grade. So if you go to grade 3, an anaplastic astrocytoma, it has components which are visible on the T2 weighted image. It's heterogeneous, and it has this rim of relatively reduced diffusion. So there are rims which are corresponding to increased cellularity. And if you go now to the glioblastoma, which is unfortunately the most malignant tumor, but at the same time also unfortunately the commonest primary brain tumor, typical features are cysts, irregular structure, enhancement, and this one is spreading and thickening the corpus callosum. There is enhancement going along, and it looks very irregular. And if you look at a second example, you have an enhancing rim with a necrotic center. In Anne Osborne books, she says 90% of the GBMs have a necrotic center with an enhancing rim, and the enhancing rim can have areas of relatively restricted diffusion, which appear dark on the ADC map, whereas the center, which is fluid, appears bright on the ADC map. So you can use that to differentiate. One word of warning is very important. There are glioblastomas which are not enhancing. You can look at the different figures. It varies from whom you read, from 10 to a third, but and that it's non-enhancing is not necessarily excluding a GBM. So in the end, you almost certainly always need a biopsy. So what determines the diffusion characteristics of a brain tumor? At the bottom, you see typical histology slides. First of all, in the middle, you see normal white matter, and you look at the cell density. Then you look at low-grade astros, anaplastic astros, glioblastoma with necrosis in cells, and then the angiocentric high cellular density with big nuclei in lymphoma. So what you see that there is an increase of the ratio between the nucleus and cytoplasma along this way, and this goes along with diffusion restriction. If you have relatively few nuclei, the water can diffuse very freely, and even freer so than the brain. And if you have a lot of cells, then the water diffusion is more restricted, and this is in tumors which are highly cellular, notably lymphoma is an example, and I'll show you more of those. That's not the only story. The other story, first, this has been confirmed, what I just said, in a seminal study where they showed from Japan, from Kumamoto, where they showed that the ADC values correlate inversely with the histological cell counts. So the more cells you have, the lower the ADC. I said it's not the whole story, it's also the tumor matrix composition, because you have seen that on the astrocytoma, the low-grade and the normal brain, there isn't so much difference in cell structure. So why is the diffusion so much increased compared to the normal brain? Well, this is due to hydrophilic substances. And one of those is hyaluronan, which is stained in brown here. And there's a study, an excellent study, which showed that the ADC increases with the content of this hydrophilic substance. So it's the nuclei plus the matrix. And that's the story, that low-grade tumors have a greater proportion of this hydrophilic substance. That gives you the background. We come to more practical things. We noticed that earlier, that's from our group, a publication that you could differentiate low-grade astrocytomas from low-grade oligodendrogliomas by doing histograms, looking at the presence of ADC values throughout the whole tumor. And in oligos, they are lower than in astros, but both are much higher than the normal white matter. So this is due to different cell counts, different matrix, and so forth. A recent publication in HNR showed differentiation between WHO grade and also histological tumors. So you see, the more malignant is, the lower the ADC gets, and even in the same group, also the oligos are lower than the astrocytic tumors. So, okay, last word, you can actually have enhancement does not mean high grade. There are also low-grade tumors which can enhance. And two examples I'm giving here. One is a pilocytic astrocytoma, and the other one is a ganglioneuroma. These are well-defined WHO grade 1 lesions that can be excised, and they also can be enhanced. So a word of caution, enhancement is not 100%. You can have infiltration of the brain by gliomatosis cerebri. That's a diffuse low-grade tumor which involves more than 3 lobes, and it's bright on flare, bright on T2, and this is the ADC map. it reduces the fractional anisotropy, it destroys the white matter tracts, so that's a diffusely infiltrating disorder. These patients can present with memory problems, with dementia, and you have to be able to recognize that. So, part 2 is non-glial tumors where DWI can be useful. Now, this is really useful to identify tumors which have a high nucleus to cytoplasm ratios. And some examples are given there. Lymphoma, medulloblastoma, central neurocytoma, primitive neuroectodermal tumors. They also have very dense nuclei with a relatively little cytoplasm. And then you can highlight them. They appear bright on diffusion-weighted imaging and dark on ADC. There's also, you can also use it to look at the presumed primary site from metastases, which I'll show you. Brief recap, you can get primary CNS lymphoma, which arises in the brain parenchyma in nearly 100%, and then you have secondary CNS lymphoma. So these patients have systemic lymphoma, and the brain is affected as a certain second stage. It's basically metastasizing lymphoma, and there the brain parenchyma is only affected in a third, but in 2/3 it's more leptomeningeal, ependymal disease, and so forth. So, examples here. Typical primary CNS lymphoma, it's a lesion which is relatively low on T2, enhances strongly and uniformly. Now, this is in immunocompetent patient. In patients with AIDS, you often have a cystic ring-like enhancement. But there is generally a decrease of lymphoma in HIV patients because they get treated more, but there's a much of an increase in the immunocompetent population. So lymphoma is going to be more and more important, and it's really important to know about that for the differential diagnosis. So you look at the diffusion-weighted image, the trace image, it's bright, and then it's darker than the brain tissue on the ADC map. What you see here as bright, this is the surrounding vasogenic edema. We have a PET MR, so we use it sometimes for this, and this is FDG uptake. So these tumors take avidly up the FDG, and this is the corresponding co-registered T1 weighted image. They respond very well to treatment. They even respond to steroids, and it's also known as vanishing tumor. They melt away. This is post-treatment. No more FDG uptake. There's just some gliosis, and the tumor has disappeared. Secondary CNS lymphoma, as I mentioned before, is more an enhancing structure around the ependyma, and this is much more elegantly shown here on the FDG. So it takes up FDG, but you also see these enhancing structures. And then you also have to know about the intravascular B-cell lymphoma. If you just see this, you could say this looks like multiple emboli, but what's strange about it is you also have edema around it. So you have vasogenic edema, and you have this restricted diffusion. And this was intravascular B-cell lymphoma, also secondary lymphoma. So another tumor, this is a tumor which occurs in young patients. I said favorable prognosis. It's central neurocytoma. It's an intraventricular tumor, and this has also a high cellular density. And on CT, it often shows calcification, has little cyst, enhances. This is the susceptibility-weighted imaging showing some artifact. And if you go to diffusion-weighted imaging, it's like the lymphoma. It's bright on DWI. It's dark with cysts in the ventricle, but it's an intraventricular tumor. And this is the diffusion tensor imaging showing that the tracts are displaced rather than invaded by this intraventricular tumor. So the last one, a nice paper to recommend to look at the diffusion characteristics there. So if we then have another example of a pineal tumor, it's T2 weighted. The pineal tumor has seeded, and you see that there are metastases seeding along. So pineal tumors, you know, there's a lot of differential diagnosis. Ultimately, CSF is probably a good way to find out what it is. But in that case, diffusion-weighted imaging shows that this is, again, probably a primitive neuroectodermal tumor. It's bright on diffusion weighting, the primary, and look how you also see the metastases. So, next point, you all heard about this, differentiation of cystic lesions. So this is where DWI comes in really very handy in the clinic. And epidermoid tumors, for example, have a reduced ADC. Arachnoid cysts have increased ADC perivascular spaces. I will show you examples of hematomas. Depending on the stage, they can be either restricting or not restricting. And then you have cystic metastases, necrotic primary tumors. And the famous thing is that bacterial abscesses, they are dense in the center, so they have restricted diffusion. It becomes more difficult with TB abscesses because they can behave both ways. Going to examples. This is a classical epidermoid tumor. It looks isointense to CSF on T1 and T2. And if you do a diffusion-weighted image, you see it's here grossly bright. And it shows you the extent and the infiltration of this epidermoid tumor, which is relatively benign and has a good prognosis. Arachnoid cyst, or perivascular spaces, or cystic structures, they are dark on diffusion-weighted imaging and very bright on ADC. So it's easy to distinguish them. There are also other characteristics, but it comes in practically. This is a recent case last week presented at our neuro-oncology meeting. A patient referred to the neurosurgeons. They've been trying to shunt this cyst. The patient had some nondescript symptoms. They didn't know and they couldn't drain it and nothing happened. And nobody ever had thought of doing a diffusion-weighted image. Diffusion-weighted image is, yes, of course it doesn't drain. It's an epidermoid cyst. Don't waste your time. So this is really practically very important for the differential diagnosis. Moving on to the famous cases of abscesses, you all probably in the audience have heard about this now, that if you have a ring-enhancing lesion with edema around, and it is very bright on diffusion trace-weighted image, and it's dark on ADC, this is a frontal abscess. Yeah? And you see that there's vasogenic edema, which is bright on the ADC. So if a dark center surrounded by some edema, you have to think bacterial abscess. And there's also a nice paper showed that the ADC values correspond with the actual bacterial count. So the more bacteria you have in there, the lower the ADC. What about this? If you have a cystic metastasis, like from CA breast, ring enhancing, but it looks like water in the middle. This is ADC, and this is the diffusion trace image. So this looks like free diffusion, cystic metastases, like the cystic components of the GBM I have shown you earlier. So what about this then? What do you think? Ring-enhancing lesion? Vasogenic edema? Dark on DWI? Increased diffusivity on ADC? Sorry, who said abscess? Well, it's not an abscess. Well, of course, I hoped you would say this is going to be a metastasis or primary tumor. But as it happened, you have to know about the differential diagnosis. This was after anti-toxoplasmosis treatment. The lesion disappeared, and toxoplasmosis doesn't behave like bacterial abscesses. They have an increased diffusivity. So if you have the appropriate clinical context, you have to think of toxoplasmosis if it looks like a free diffusion in the center. And TB can behave both ways, as I showed you. Hematoma, very important. This was a clinical case. The house officer came down. The patient's been on antibiotic now, has the abscess resolved. And I said, this is not an abscess. We have documented evidence the patient had a bleed on CT. This is just a subacute hematoma. You can see the hemosiderin rim, and it's restricted in the diffusion. And the tricky thing about hematomas is that if you follow the evolution, they are actually not restricting in the acute and not in the chronic state, but there's a subacute stage where they may show restricted diffusion and be confused with abscesses. Differential diagnosis of metastases, elegant paper, highly recommendable to read. So they saw patients with small cell carcinoma of the lung. They have small nuclei. They are reduced ADC, whereas well-differentiated adenocarcinomas, they're on the higher end. So if you have actually a patient with metastases, like this one, and it's restricting, then you can suggest that it may be small cell of the lung. They didn't know about that. They did lung CT and biopsy, and it was confirmed. And another case, which was actually in the same meeting, a patient with a squamous cell carcinoma and the metastases shows increased diffusion. So you can also see, depending on the primary tumor and what cellularity the primary tumor has, the metastases in the brain may appear differently. Tumor mimics, so important to know. If you have the horseshoe appearance with a crescentic open ring enhancement, and you see also some restricted diffusion. This makes you think immediately. Anyone in the audience? Tumefactive MS. Okay, exactly. And this is when the patient was transferred for brain biopsy. We repeated the imaging. It had actually already gone down. Another example of tumefactive MS with a ring that is restricted and some edema around. So this is always something to think of. Now, what about this patient? It's an HIV-positive patient with visual symptoms. Now, could this be a glioma infiltrating along the corpus callosum? Yes, it could be. But if you look at the diffusion-weighted image, you see this flame-like edge, and this is very characteristic, this high signal edge of progressive multifocal leukoencephalopathy. This is a case with swelling of the hippocampus, high signal. It could be a glioma, but the patient actually had a repeat scanning and he presented to the memory clinic. He had an autoimmune encephalitis and antibodies against calcium channels tested positive. Something to think about. I'm not sure whether Pia is going to mention in her talk radiation necrosis, but here is a patient with post-radiation therapy showing some enhancing structure, and if you then you don't know whether it's tumor recurrence or radiotherapy, there are various ways to look at. On diffusion, the ADC map is actually increased if it's radiation necrosis, and this is the FDG PET, show no uptake, and this is now a dynamic contrast enhanced perfusion imaging. It's a slow slope and uptake. So you have to think of radiation necrosis. The last 2 minutes, I'm going to go through extraaxial mass lesions. A meningioma, obviously nice if you have typical tail and so forth. Sometimes it's not so clear. And then you can do something which is very useful. This is also useful if you have a question whether it's residual scarring or residual tumor following operation. This is doing a gadodotatate PET scan. This is a somatostatin analog, and almost all meningiomas have somatostatin receptors in it. And if it's positive, then it's likely to be a meningioma. Differential diagnosis is wide. Here we have an area with severely restricted diffusion, and this was a bone metastasis of a Ewing's. So extraaxial mass. This is sarcoidosis, 2 cases. Sarcoidosis can give you, those who were in the imaging interpretation session, we talked briefly about it, but these are lumpy, bumpy dura, and this is a bigger mass lesion. Same can be dural metastases from CA breast and other things. This is the recent case showing that this can look almost like a subdural, but it enhances and then it infiltrates the bone, it infiltrates the soft tissue, and if you know the patient has actually a B-cell lymphoma, then this is an extraaxial metastasis or manifestation of a B-cell lymphoma. So I hoped that in that brief and relatively quick tour, I managed to convince you, if you look at it and you don't want to use more sophisticated techniques like the next speaker will talk about, like perfusion imaging, just using contrast-enhanced and diffusion-weighted imaging, you can get very far in narrowing down the differential diagnosis and coming up with possible histologies and also coming up with alternative diagnosis. And I think that's the images I always look first, contrast-enhanced and diffusion-weighted. But diffusion-weighting, always look at the DWI together with the ADC. I don't know whether you have any of you have machines who don't produce automatic ADC maps. That shouldn't exist anymore, but you need it. So thank you very much for your attention.